Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today in my lesson I touch briefly on the facial nerve. Facial nerve is a bit clinically important and its course intracranial and extracranial part is a bit complicated and it is associated with the motor functions and secretomotor functions and the sensory functions. All these will be dealt with in detail. Before that, I am going to briefly touch the neuroanatomy of the facial nerve. It is the seventh cranial nerve, and look at this particular picture showing the supply of the various branches of the facial nerve, innervating the face and parts of the scalp and the neck. This picture shows the section of the pons. You can see in this particular picture location of the facial nerve nucleus and that of the absence nerve nucleus. And we see the nucleus solitarius and the spinal nucleus of the trigeminal and the pontine nucleus of the trigeminal for general sensations. And you look at the salivary nucleus, etc. Then you see the course of the facial nerve after entering the internal acoustic matrix. It is associated with the vestibulocochlear nerves and its course in the temporal bone, ultimately emerging out of the stylomastoid foramen. This is what you see in this picture. Then it is same as the facial nerve in the temporal bone. It has got the cysternal segment, intracanalicular segment, labyrinthine segment, and tympanic segment. Its branches to the stapedius and is joined by the chorda tympani for the taste sensations. And it has got the mastoid segment and the extracranial segment. This is a facial nerve has got the long course through the temporal bone. So it is subjected to inflammatory injury when there is otitis media and other inflammatory conditions in the part of the temporal bone. Then coming to the features of the facial nerve. The seventh cranial nerve contains the motor, sensory and parasympathetic fibers. Innervates the many structures of face and neck. This picture shows the motor pathway for the facial nerve. It has got the upper motor neurons and the lower motor neurons. It has got the motor nucleus in the pons, which consists of the dorsal nucleus and the lateral nucleus. Dorsal nucleus innervates the muscles of upper face. It receives the supranuclear fibers from the motor cortex of both the hemispheres, and in turn supply the muscles of upper face. So upper face is bilaterally innervated. Well, the lower face receives its nerve fibers from the lateral nucleus of the facial nerve nucleus and the pons. This lateral nucleus of the facial nerve receives its supranuclear fibers from the contralateral cerebral cortex. So, the lesions of the upper motor nerve it is the lower face that is affected upper face being spared. Then coming to the nucleus of the facial nerve, located in the pons ventromedial to the sixth nerve nucleus. Well, it has got three components. It has got the motor, sensory, and secretory motor in order to carry out the different functions. What are the functions? It has got motor supply to the facial muscles for the purpose of executing the voluntary action. It has got the secretory motor function supplying the submandibular and salivary glands and the lacrimal glands for the general facial afferents to carry out the functions of the salivary and the lacrimal glands. Taste sensation from the anterior two-thirds of the tongue as visceral afferents, and cutaneous sensation from the pinna and the external artery meatus for general sensory perception through the afferents. So the facial nerve has got the motor function, secretory motor function, and sensory function. Coming to the motor pathway. Motor pathway has got the upper motor neurons and the lower motor neurons. Well, for the upper motor neuron, which extends from the cell body, is located in the cerebral cortex. Okay, the axons run as the corticobulbar fibers pass through the internal capsule, reach the motor nucleus in the pons. This dorsal nucleus receives its fibers, that is upper motor neurons, from both the hemispheres, whereas the lateral nucleus receives its upper motor neurons from the contralateral cerebral cortex only. Whereas the lower motor neuron, which starts from the nucleus of the facial nerve, runs downwards to exit at the level of pontomedullary junction and supplies the muscles on the same side of the body in order to carry out the voluntary expressions. But emotional expressions are controlled by limbic and extrapyramidal systems. So the facial nerve is controlling the voluntary expressions. Remember that. Involuntary expressions like laughing, etc., are carried out by the limbic and extrapyramidal pyramidal systems. Then this is the superior lateral surface of the cerebral cortex showing the various areas. You got the premotor areas in the frontal lobe, you got the motor area in the precentral gyrus, you got the central sulcus of Rolando. Well, you got the postcentral gyrus carrying out the all modalities of the sensations. You have got a sensory associated area and visual center in the occipital lobe, the auditory and auditory associated areas in the temporal lobe. Broca's area for the expression of the speech is located in the frontal lobe, close to the lower part of the premotor areas, premotor gyrus. Then coming to the secretory motor pathway, its nuclei are located as the salivary nucleus and the lacrimal nuclei in the pons in close proximity to the motor neuron nucleus posteriorly. The nuclei receives the fibers from the hypothalamus and via the nervous intermediates innervates the salivary and lacrimal glands. Sensory pathway, it has got the taste sensation and the general somatic sensation. Taste sensation from the anterior two-thirds of the tongue carried by the cardia tympani branch of the lingual nerve enters the geniculate ganglion. From there, fibers run into the nucleus solitarius in the pons and cross to the opposite side to reach the thalamus. From there to the area in the hypothalamus and the postcentral gyrus. Then for the general sensory pathway, the sensations carried from the area of the external artery meatus and the pinna, they reach the pons from the geniculate ganglion to enter the trigeminal nucleus and reach the thalamus and the postcentral gyrus on the contralateral aspect of the cerebral hemisphere. So these are the sensory pathways of the facial nerve. To mention again, taste sensation from the anterior two-thirds of the tongue via cardia tympani goes to the geniculate ganglion, from there to the nucleus solitarius, then nervous intermediates on the contralateral side carries these modalities of the sensation of the taste to the thalamus and the postcentral gyrus and to some extent to the hypothalamus. Whereas general somatic sensation from the that is external auditory meatus under the pinna, they reach the geniculate ganglion, then sensory nucleus of the trigeminal nerve in the pons, from there cross to the opposite side, run in the medial lemniscus and go to the thalamus, from there run to the postcentral gyrus for the perception of the sensory modalities. This is the sensory pathway of the facial nerve. Then let us understand the course of the lower motor neurons. Lower motor neurons have got the various segments. Lower motor neurons, their cell bodies are located in the nucleus of the facial nerve in the lower parts. Okay, they have the intracranial segments and the extracranial segment. Intracranial segment of the facial nerve is that one which run from the nucleus of the facial nerve and end at the pontomedullary junction. So this part of the facial nerve is in close relation to the nucleus of the sixth nerve. It is closely related to the pyramidal fibers, and still laterally it is related to the eighth nerve nucleus and other structures of the brainstem, like the ascending sensory pathways like the medial lemniscus, and it is also associated with the parapontine reticular formation. And you will see the clinical manifestations depending upon the extent of the infarct secondary to the ischemia. So this is the intracerebral port segment of the intracranial part of the facial nerve. Then comes the extracranial segment. Extracranial segment, from the point of its exit into the entry into the internal auditory meatus to its termination from the stylomastoid foramen to supply the muscles of the face. So that is the extracranial segment. Extracranial segment has got a long course through the temporal bone. It is further divided into medial segment, labyrinthine segment, then you have got the tympanic segment, then mastoid segment, and ultimately extratemporal segment. So please understand this part of the facial now. That is meatus segment that passes from the internal acoustic meatus into the medial canal, then exit from the internal acoustic meatus. From that point, it is a labyrinthine segment until it reaches the geniculate body, geniculate ganglion. From there, it starts its tympanic segment, which runs in the facial canal. Then you have got the mastoid segment. Then ultimately exit from the stylomastoid foramen to supply the muscles of facial expression. During the course of facial nerve through the temporal bone, it gives away the branches to the stapedius, and it will receive the chorda tympani for the taste sensation. This is in brief the anatomy of the facial nerve. By and large, it is very important to understand the basic principles of neuroanatomy to interpret the clinical signs of the neurological lesion. Well, coming to the clinical considerations of the facial nerve. Facial nerve can present with the upper motor neuron lesion or lower motor neuron lesion, and some of the surgical injuries resulting in the dysfunction of the facial nerve. So this picture shows the upper motor neuron lesion signs and the lower motor neuron. Bell palsy is the lower motor neuron lesion. So it causes the total facial paralysis on the side of the lesion. This is important. Whereas stroke is the upper motor neuron lesion. Okay, it affects the contralateral face involving the muscles of lower face and sparing the upper face. Then let us go into the details of the upper motor neuron lesion and the lower motor neuron lesion before we go to the various syndromes resulting to the infarcts and in the pons. The upper motor neuron lesion. This lesion could be anywhere from the precentral gyrus, the area of the upper motor nerve cell bodies, along the course of corticobulbar fibers till its nucleus in the pons. So the upper motor neuron lesion can occur in any part of the facial nerve in its course from the precentral gyrus down to the nucleus of the pons. So it could be due to stroke, it could be due to tumors or the infections or vasculitis. It results in the contralateral lower face weakness and contralateral hemiplegia, sensory loss, depending upon the extent of the lesion. You have seen this picture, yes. This is stroke involving the contralateral lower facial weakness. Upper motor neuron lesion could be in the cerebral cortex, internal capsule, or in the midbrain. So what are the features of the lesion in the cerebral cortex? It involves the facial nerve in the precentral gyrus. So it results in the contralateral lower face weakness and contralateral hemiplegia depending upon the extent of the lesion. Seizures as the characteristic feature when the lesion in the cerebral cortex. Then dysphagia is another presentation of the lesion in the cerebral cortex if it is in the dominant hemisphere. The center for the speech is located in the dominant hemisphere, remember. And dysphagia is the manifestation if the lesion in the dominant hemisphere. Then lesion in the internal capsule. It results in the contralateral lower face weakness because it is upper motor neuron lesion, contralateral hemiplegia, contralateral hemianesthesia, and also affects the visual and auditory disturbances depending upon the size of the lesion. But there are no seizures, no aphasia, and recovery is faster. So this is the picture representing the internal capsule with the anterior limb, genu, and the posterior limb. Coming to the lower motor neuron lesion. The lesion could be anywhere from the site of the facial nerve nucleus down to its termination to supply the muscles of facial expression. It could be due to stroke, due to tumors, infections, etc. It causes ipsilateral total facial paralysis. Ipsilateral total facial paralysis, including the upper as well as the lower. Then there is a contralateral hemiplegia. If the lesion in the pons, okay, it is described in various syndromes: Mobius syndrome, Millett-Gobler syndrome, and Foley syndrome. So it's very easy to understand the manifestations of these particular syndromes. This is the Fowey syndrome. Remember three important points in the Fowey syndrome, or four important points. It is associated with ipsilateral facial palsy, including the total face. Number two, it involves the sixth nerve, causing the paralysis of ipsilateral rectus, resulting in the weakness of the abduction of the eyeball. Number three, it involves the parapontine reticular formation, a center for the lead horizontal gaze. There is ipsilateral horizontal gaze paralysis. Okay, with contralateral spastic hemiplegia. So these are the four components of the Fowey syndrome. What are they? Ipsilateral facial nerve palsy involving the total face, ipsilateral sixth nerve palsy, ipsilateral horizontal gaze paralysis, then contralateral spastic hemiplegia. Why is it due to? Due to the lesions in the paramedian branches of the basilar artery. Okay, is it clear? Well, sometimes this lesion could be little bit extended, resulting in the injury to the other structures in the pons, like ipsilateral loss of pain and temperature, because it involves the nucleus of the trigeminal nerve, that is spinal nucleus. It is the spinal nucleus carries the fibers for pain and temperature. Okay, they cross in the spinal cord and ascend upwards to reach the pons in the medial lemniscus. Then there is ipsilaterally sensory neural deafness because of the involvement of the vestibulocochlear nerve. Ipsilateral Horner syndrome because of the involvement of the sympathetic chain. The contralateral hemianesthesia because of the involvement of the medial lemniscus. Okay. These are the extended features. If the infarct involves the not only medial part of the pons, little lateral part of the pons at the inferior pontine region. Then you have got the Millet-Gobler syndrome. Well, this is again the infarct in the medial inferior part of the pons due to the involvement of the paramedian branches of the basilar artery. It was first described in 1858. It was called initially as the facial abscess pyramidal syndrome because this lesion involves the facial nerve nucleus, abscess fibers, and pyramidal fibers. That's why it is described as the facial abscess pyramidal syndrome. It is simply only it has got three components. It does not result in the horizontal gaze paralysis. Okay, so this is the Millet-Gobler syndrome with three important features: contralateral spastic hemiplegia and ipsilateral total facial paralysis, along with the abscess paralysis. There is no involvement of the horizontal gaze. So this is the difference between the Fowlis and the Millet-Gobler syndromes. So common causes could be ischemia, tumors, neurocysticercosis, tuberculosis, and multiple sclerosis. This is the Millet-Gobler syndrome, wherein there is a facial fasciculi here, there is absence fasciculi here, and the pyramidal fibers. This is the infarct here. Good. Then comes about Mobius syndrome. It's a very rare disorder. Cause is not known, probably due to the vascular insufficiency during fetal development, interfering with the formation of the facial nerve nucleus and the sixth nerve nucleus. So, lack of facial expression, inability to close the eye, inability to close the mouth, inability to move the eye laterally, and delayed speech and dental anomalies associated with high arched palate and the chest anomalies. But intellect is normal. These are the phases of Mobius syndrome. Look at this picture. He is unable to open the eyes. There is the lateral rectus paralysis. Well, lesions in the extracerebral but intracranial portion of the facial nerve. This is the lesion between the pontomedullary junction from where the facial nerve exit to the point of internal acoustic meatus where the facial nerve takes its course in the temporal bone. The more common lesion here is the acoustic neuroma. So results in the ipsilateral facial nerve palsy with the involvement of the vestibulocochlear nerve. Remember, long tracts are spared. There is no associated hemiplegia or sensory losses, etc. This is purely involvement of the facial nerve and the vestibulocochlear nerve due to acoustic neuroma in the extracranial, intracranial but extracerebral segment of the facial nerve before it enters the temporal bone. Then comes to the lesions of the extracranial part of the facial nerve. That is, it goes through the temporal bone. So, infections like herpes simplex results in Bell's palsy, varicella zoster results in Ramsay-Hunt syndrome, that is the Lyme disease, and HIV can affect the facial nerve in its extracranial course. Demyelination associated with GBS, there could be vascular lesions, trauma, neoplasms, etc. This is the patient with right-sided facial nerve palsy with drooping of the eyeball, lack of frontal creases, widened palpebral fissure on the right side. Nasolabial fold is less prominent. There is drooping of the angle of the mouth and drooling of the saliva on the side of the paralysis. You can see the same patient with facial nerve palsy. Inability to wrinkle the eyebrows, okay, drooping of eyelids, inability to close the eye, inability to pull the cheeks, asymmetrical smile, drooping of corner of mouth and the dry mouth. So these are the some of the features of the Bell's palsy. Then this patient is having the pain at the angle of the jaw, probably is going to develop the rash, resulting in a syndrome called Ramsay-Hunt syndrome. It is again a facial nerve palsy, lower motor neuron, due to the lesion in the extracranial segment of the facial nerve, that is, the lesion in the close to the geniculate ganglion caused by the varicella zoster. So the manifestations are the pain, rash, and the facial palsy on the same side of the lesion. So these are the features of Ramsay-Hunt syndrome. Let us go into that particular aspect. Facial nerve palsy, lower motor neuron, involving the ipsilateral total face, vesicular eruptions, rash over the pinna and external canal, hyperacusis, loss of taste over the anterior two-thirds of the tongue because of the involvement of the chorda tympani, tinnitus, and the vertigo because the eighth nerve is also affected because of the inflammation in the particular area, sensory neural deafness, nausea, vomiting. So these are some of the features of Ramsay-Hunt syndrome. It is caused by the varicella zoster involving the geniculate ganglion and the facial canal. And we treat the patients with the steroids and the acyclovir. Most of the time they will improve with variable response. If the patient is suffering from some comorbidities like diabetes, etc., the response will be not that satisfactory. But most of the occasions, the condition improves with steroids and acyclovir. Well, this is in brief the talk on the neuroanatomy of the facial nerve and its lesions at the various levels of its course, from the cortex down to its branches supplying the muscles of facial expression. Thank you very much for patient listening, and I'm sure you will appreciate this particular topic and remember the points to apply in your examinations and the practicals. Thank you very much, and we'll meet you again in the next class. Until the time, bye bye.